94% of all maternal deaths occur in developing countries, and sub-Saharan Africa accounts for 2/3 of these deaths. And in a way, this number already tells you that, if they're all happening in poorer parts of the world, that the majority of these deaths are preventable. So in high-income countries, we found ways of preventing a lot of these deaths. And one way of doing it is to have skilled birth attendants, because they can prevent many maternal deaths. And these skilled birth attendants mostly, not exclusively, work in health facilities. Okay, so what does the WHO have to say about intrapartum care? Intrapartum care is the care through stage 1, 2, and 3 of labor. So 1 is the opening of the cervix, then 2 is the pushing out of the baby, and 3 is the placenta delivery. Yeah, so intrapartum care. So the World Health Organization states quite clearly that all women have a right to a positive childbirth experience. And they specifically say that you should have respect and dignity, a companion of your choice. There should be clear communication by maternity staff. There should be pain relief strategies, and you should be allowed to be mobile in labor and choose a birth position of choice if there are no medical reasons why you shouldn't do so. So the World Health Organization has got this sort of aspiration of positive childbirth experiences for women across the world. But and this is also described how to achieve this in the user's manual. So for midwives and obstetricians, there's a user manual, and it aims to improve the health and well-being of women and their babies. And one of the most important issues highlighted is supportive care for a positive childbirth experience. But of course, the World Health Organization also knows that this is far from the reality for many women delivering. And so many women experience disrespectful and abusive treatment during childbirth in facilities worldwide. So this is one of the World Health publications. And so there are more recommendations for intrapartum care for a positive childbirth experience. Because they state that the mistreatment during childbirth is a violation of rights and trust between women and their healthcare providers. And there's a call for greater action, for more dialogue, research, and advocacy. And so we followed this call, and we are sort of doing more research on this issue, important issue. So it's a global health challenge, and some academics have sort of worked on this, and they define it as the violence exercised by health personnel on the body and reproductive processes of women during pregnancy or delivery. So it's not just intrapartum care, but also during pregnancy, as expressed through dehumanizing treatment, medicalization abuse, and the conversion of a natural process of reproduction into a pathological one. And so if you ask me what is obstetric violence, it's sort of between gender-based violence, because women give birth to children, so it's aimed against women, and institutional violence, where people in power in an institution, so a healthcare facility, exert their power over their clients. And so it can happen during pregnancy, childbirth, and postpartum, so after you've given birth. So just to be clear, obstetric violence is not something that the World Health Organization uses, but we have used in our study. So disrespect and abuse is World Health Organization parlance, and obstetric violence in the more in the academic literature. Let me remind you that SDG 5.2 says that we should eliminate all forms of violence against women and girls. and clearly obstetric violence is such a form of violence. So what are the manifestations of this obstetric violence? So far it's been very abstract. I've been talking in the abstract. And so the Women's Global Health, the Women's Global Network for Reproductive Rights has sort of put this picture together for us. So this is an alliance of many different organizations, and if you sort of look at the pregnant woman in the middle, she can face physical violence. This can be invasive practices or unnecessary use of medication. It can be forced and coerced medical interventions, for example, the use of forceps when it's not medically indicated. She can face verbal humiliations, and she can be denied treatment during childbirth. She can be abandoned and neglected. Staff can disregard her needs and pain. Some women are detained in facilities for the failure to pay for the treatment or medical devices that they received, or they can be at the end of dehumanizing and rude treatment. There's also discrimination that many women report, which is based on race or ethnic or economic background, their religion, their HIV status, among others. And so in any case, each of these constitutes a grave violation of human rights, like the right to equality, freedom from discrimination, information, integrity, health, and reproductive autonomy. So Bowser and Hill are a key publication in this literature on obstetric violence, and they list 7 different forms. So let me start to the top right. So there's non-confidential care. So one common issue is that while the woman is giving birth or being examined during pregnancy, that there are other people present in the room without her consent and without any need. So this is beside the necessary medical staff. Then non-dignified care. The most common complaint here is shouting and being yelled at, being mocked. Your body shape is criticized. That is what falls under non-dignified care. Discrimination, well, I've already mentioned this. It can be on the basis of your age or ethnic background, for example. Then abandonment and neglect. So very often during birth, women report that they requested help, but it was ignored. And then the detention in facilities, as I said, very often women are made to stay behind after giving birth until she or her relatives pay. To leave the hospital. Sometimes they're also made to do chores, so for example, mopping the floors there. And then physical violence. So this form of obstetric violence is particularly horrifying. So women are slapped, they're being hit, they're being restrained if they want to get into a different position while giving birth. They are kept from expressing any pain. So quite commonly also in this category of violence, women report that health personnel pushed on her abdomen to help push the baby out. And then there's non-consented care, so there's no prior approval sought for medical interventions or, for example, for internal vaginal examinations. So these are the sort of 7 forms of obstetric violence that are used in this relatively small literature. What are the consequences of this obstetric violence? Of course, it's terrible for the individual woman. It increases her trauma, it increases the likelihood of birth complications and death rates for the woman as well as for her baby. It clearly contravenes WHO recommendations on intrapartum care. It violates the bodily integrity of women, her right to health, respect and freedom from discrimination, privacy and choice. So, but it also does something else. It diminishes the woman's trust in healthcare professionals, and this is quoted as a major impediment to facility-based deliveries. Women don't want to go there because they fear this kind of obstetric violence. And there are numerous studies that sort of give us grounds to believe that women are really not wanting to sort of go to health facilities. And this diminishes greatly the incentives for institutional delivery, and it undermines these facilities that have been created for safe childbirth. So let me now zoom in on Ghana. Let me stress once again that this is not a problem in particular for Ghana. It is a global problem, but our study site is in Ghana, so let me tell you a little bit more about Ghana. So Ghana has got a higher than global average maternal mortality rates. So Ghana still has 310 deaths per 100,000 deliveries. So this is 3 times higher than the recommended cutoff for the from the WHO, or threshold from the WHO. There's higher prevalence in rural areas, and the Ghanaian government has clearly identified this as a problem. And sort of maternal mortality rates is a major component of the public policy agenda, health policy agenda. So there have been enormous efforts to increase facility-based deliveries. Yeah, remember, most of these maternal mortality deaths can be prevented with good care, and good care is in healthcare facilities, yeah, in principle. And so we have, since 2008, the Ghana National Health Insurance Scheme that has sort of strengthened community-based health planning and services. So in principle, every woman should be able to sort of access a facility for birth. Maternity care is in principle also free of charge. And there's also antenatal services, and they've been a huge success. About 90% of women, pregnant women, use these antenatal care services. However, so they go to antenatal services, but they don't go to the facilities to deliver. So the rate of skilled birth deliveries is between, depending on the different studies, is between 55 and 63%, 54 and 63%. This has got obviously a number of different reasons, but one reason is obstetric violence. So what do we know about obstetric violence in the Ghanaian context? So we've got the Demographic and Health Service for Ghana, surveys for Ghana. But women are not asked about their birthing experiences. Yeah, they're asked relatively straightforward questions, how many pregnancies and how many children they've had and so on, but not about obstetric violence. And then Ghana conducts some maternal health surveys, and these also do not give us any idea about obstetric violence. There are some patient satisfaction studies. And interestingly, like the rest of the studies I know for West Africa, there's typically very high rates of patient satisfaction. So this completely contradicts, all of the sort of little bits of evidence we have on obstetric violence. So patients sort of have like between 60 and 80% they're satisfied or even highly satisfied. But qualitative studies suggest that women prefer home births due to obstetric violence in the facilities. And there is a big cross-country study on obstetric violence that actually includes Ghana as one of the 4 studies. This was published by Born et al. In the Lancet in 2019. And we have a very small specific study on a hospital in Ghana, in a urban hospital, and the sample size was relatively small, 250 in this Tema General Hospital. Okay, so the research objectives for our study is to investigate the dimensions that abuse and mistreatment in Ghana take, and to estimate the prevalence rate of obstetric violence in all these different forms. And then we analyze the associated factors of obstetric violence. And that's what I'm going to talk about for the rest of today's lecture. Now, we also want to explore this perspective of the health workers. You know, why do they do this? Why do they use violence in the delivery room? And explore further more systemic reasons for this type of violence. So number 4 and 5 is really much more Abina's territory, and she's just published, so this is the first publication in my research group of this year. So this is a qualitative study where she uses the citation from one of the midwives for her title, "We beat them to help them push." Because it's very much so what Abina argues in this paper is that midwives told her in this qualitative study that this is helpful. This is meant to be helpful to women, to sort of exert all this pressure on them so that they deliver a healthy baby relatively quickly. But I will not be talking about this today. So the study setting is the Ashanti and Western region. So you can see a map of Ghana here. These regions have 8 million inhabitants. This is about a quarter of Ghana's population. And the facility-based delivery is pretty much sort of what we expect from these Ghana-wide statistics in the Ashanti and Western region. They're pretty similar, yeah. Okay, so we picked 4 hospitals in each region, 2 urban, 2 rural hospitals. To give you an idea what these hospitals look like, our collaborators have taken these pictures for us. Yeah. Okay. So we had a mixed method approach because, as I told you, we have a number of different research objectives. So let me focus here on the facility-based cross-sectional survey that we conducted. So the purpose is to ask women about their birthing experiences. So we went to postnatal and immunization clinics. So put a picture here. So women come for postnatal checkups or to have their babies immunized. And we interviewed them and download directly into the Survey to Go software, which was then uploaded, and this took place from September 21 to February 22. We trained 20 enumerators specifically for this sensitive task. And in total, we were able to interview 1,854 women. So who did we include in the study? We included anybody who was over 15 years old, who'd given birth within the past 24 months, and who'd given us consent. The questionnaire was our own design. It's based on the 7 different types of obstetric violence classification by Bowser and Hill that I showed you earlier. And we piloted this questionnaire, but it's not validated. We didn't, to our knowledge, there's no validated survey instrument on this question. Just to give you an idea what Albina did in addition, she conducted qualitative interviews with a total of 30 midwives and 35 mothers, and for the publication that I just cited, she used thematic analysis with an in vivo qualitative data analysis software. So I will be showing you some data, lots of data in a minute. I'll give you a little bit of descriptive analysis and then multivariate analysis to sort of just give you an idea how common this phenomenon of obstetric violence is and what the associative factors might be. So let's start with the personal and demographic characteristics of our sample of 1,854 women. So how old are they? Keep in mind these are all women who've given birth, so it's not that surprising that they're sort of all, or a large percentage of them are between 20 and 34 years of age. So we've got very few older mothers and very few teenage mothers. Their education is, most of them have had at least some education. So there's basic education, so primary and primary completed, and secondary education, and some have tertiary education, but it's the minority. I don't know what happened here to my percentage signs, but basically the marital status you can see in my donut. There's it's mostly orange. Most of the women interviewed are married. 72% of the women are married. Some are single, some live with a partner or divorced or widowed. Then income. So only very few women give a high household income of 2,000 cedis. To give you some idea, 1,000 cedis is or was then about 80 euros. So most women have got a relatively low income, or stated a relatively low income. We are aware this is also a sensitive question, but we sort of put these in income groups. People didn't have to tell us exactly how much they had, but within certain brackets. And then where do they live? We did have more urban than rural participants. Most of them in this region are Christian, some are Muslim, and some traditional African religions. So employment, as it's typical for, so Ghana is a low middle income country, very typical for this type of country. Most people are employed in the informal sector. Yeah? And it's a very high labor force participation rate here. Most women work also outside of the household. There were only very few who were housewives, unemployed, or students. Formal sector employment is relatively rare. So what could the women tell us about their births? So most births in Ghana are attended by midwives. Doctors are typically only part of the birthing process when there are medical complications and when a C-section becomes necessary. And then some nurses and community health nurses also attended births, but that's the minority. Yeah. So the type of delivery is about 1/5 by cesarean section, relatively high when compared to some other settings. I should maybe say that these were all public hospitals, no private hospitals that we surveyed. There the rate of cesarean sections is even higher, and there are a lot of elective cesareans. But ours were only public hospitals. And then about, again, 1/4 told us that there were birth complications. Okay, so what do women tell us about their experiences of obstetric violence? 2 out of 3 women that we asked told us that they'd experienced some form of obstetric violence. Pretty shocking. So out of these women, most of them experienced multiple abuse. So if you think about it, when somebody restrains you or slaps you, very often there's also verbal aggression. So you would, so very often these things go together. Yeah. Okay. And then I'm comparing here the prevalence by type. Urban is the blue and rural is the green. You can sort of see these bars are pretty similar. We tested obviously whether they were significantly different, and they weren't. So any form of violence is very similar in the two. Then the next common, so the most common type of obstetric violence is non-confidential care and lack of privacy. So somebody else in the room, for example. And then neglected or abandoned care. So I asked for help, but nobody attended to me. Non-dignified care is the shouting, the humiliation, physical abuse. Discriminated care not reported all that often, and non-consented care also not very frequent. And the detention in health facilities also relatively rare. So if we look at the specific dimensions here, so the non-confidential care, as I kept already saying, is the presence of others without consent, and also not being covered during the delivery. So not having a sort of modesty sheet across you, for example. So abandonment of care, so it's the ignoring and the left unattended was the biggest concern that the women reported to us. So the non-dignified care is the shouting, the yelling, the humiliation, the blaming, scolding, or being criticized, or my partner and spouse, family members were disrespected. Then physical violence, so here, this is really gruesome. Stitching after, so episiotomies are very common. Obviously also if there's no episiotomy, tearing is very common in childbirth. So stitching is completely normal part of facility-based healthcare treatment, but this stitching very often happens without anesthesia. And then the restriction from my reaction to pain and forcing me to keep quiet when in pain was also a common complaint. And then the slapping of the face, thighs and back. Okay, and then we asked women when they said, were you discriminated against? Why was this? There were multiple reasons that women sort of said, it's because of my socioeconomic status. Remember, a lot of women have very little income because of my education or because failure to pay a bribe. Keep in mind, healthcare is really, or the birthing should be free of charge, but still it's very common to be asked for payments. Yeah. So, and when I then refuse, I sort of feel that I'm discriminated against. Okay. So, sorry, maybe also HIV was sort of something, HIV status was something that some women reported. And then when does this abuse happen? Does it happen? It happens predominantly between in the second stage of labor. So interestingly, Abina found when she interviewed the midwives that midwives are of the opinion that stage 2 labor, so this is when the baby is pushed out, shouldn't take more than 30 minutes. Was their firm conviction. And so they sort of put a lot of effort and sometimes aggression and beating and shouting and other abuse into delivery within these 30 minutes. There's no medical reason for this 30-minute cutoff, and medical studies show this quite clearly. But this is what they're concerned about, and they're very worried when the baby is stillborn that their license will be revoked. So it's not only a tragedy for the baby and the mother, but also the midwives are very concerned about the legal repercussions. And this might explain some of the stresses they experience during the birthing process. Okay, so we then sort of thought, what are the associated factors of this type of violence? So first we look at any form of obstetric violence. Yeah, remember this was 2 in 3 women tell us that they experience some form of obstetric violence. This is what we examine here. There's no standard model to test this. We use the Lancet study that I mentioned earlier by Bourne et al. So they look at age. So how old are these mothers? What is their educational status? What's their marital status? And the number of births. Is this their first birth? Yeah. So okay. So we estimated odds ratios. So you need to sort of look at the horizontal line saying 1 and say if it's sort of above or below 1. Above 1 means that you're more likely with that characteristic to experience obstetric violence, and below that you were less likely to experience this form of violence. Then the lines sort of give you the confidence intervals, and we actually only find that single women are at higher risk of experiencing obstetric violence than married women, and all the other factors were insignificant. This is very similar to the Boren et al. Study and other studies that we could find in Ethiopia, for example, and Tanzania, sort of similar studies. It's very difficult to sort of get significant coefficients here, odds ratios. Okay, what was significant were a number of hospitals. So these hospitals are quite different from each other. There were 3 hospitals where we found that there was there were higher rates of violence. So this will be of particular importance when we report back to these hospitals, and will maybe also give us a pointer about good practice or better practice in these other hospitals than in comparison to these sort of high or higher violence hospitals. Then, in addition to this baseline model that I showed you, one by one, so not all of these dots together in one regression, but one by one, we added other variables. The problem is that we've got very high correlations between some of them. So for example, your income is clearly correlated with your education. So it's sometimes problematic to sort of put all of these variables into one regression. So when you were asked for a bribe, you were more likely to experience obstetric violence. And if the birth attendant was a midwife or a doctor, then you were less likely than being attended to by a nurse. So the nurses tend to be more violent towards the patients. There was very weak evidence for lower income giving you a lower risk of experiencing violence, and we're not quite sure why that might be the case. So complications during childbirth, so women who experience complications during childbirth also had a higher probability of experiencing violence, and here we can't disentangle cause and effect. So maybe because there were complications, there was more stress in the delivery room and therefore more violence, or maybe because of the violence there were complications. And then also the majority are Christian, but they experience higher rates of obstetric violence. Then we could also look at the specific forms of obstetric violence. So each column here gives you our baseline model. So this you've already seen in forms of dots. And then I move along for these sort of different types of obstetric violence. So teenagers seem to be at higher risk of physical abuse. But overall, there are very few factors that we found to be statistically significant. There is some evidence that lower education puts you at a higher risk. And there is a little bit stronger evidence that this first result that we had, that single women are at higher risk, holds for different types of violence. Okay. Now, what about HIV positive mothers? So this is a paper that we are currently still working on. So these are very new results. So obviously we globally we want to start our lives free of HIV, stay free, and reduce AIDS overall in our societies. And there are UN-supported programs to prevent the mother-to-child transmission of HIV. So ideally, expectant mothers receive prenatal care. They are HIV tested. Those who are HIV infected will receive HIV medication. So these are antiretroviral drugs, HRT. ART. And the HIV-exposed infants receive medication to prevent their HIV infection. And mothers are encouraged and follow safe infant feeding practices, exclusive breastfeeding. All of this is much, much easier to do in a facility-based health setting, and this is why it's particularly encouraged for HIV-positive mothers to give birth in a healthcare facility. So, okay. So what did we do? So Ghana has got a relatively low HIV/AIDS prevalence rate. So in our sample of 1,854 women, we had 22 HIV positive women. So this was self-reported by them. So this is a little bit lower than the general prevalence rate, but within the vicinity of. So it's about 2% of people are HIV positive in Ghana, and so we needed to sort of do more purposive sampling. So we went to these antiretroviral clinics, ART clinics, and asked 288 mothers to take part in our study. So we've got a total of over 2,000 women in our study with 310 HIV positive women. So, sorry, I'm sort of going too fast here. So then we sort of use our same regression approach as before. So we use our baseline model, but add the HIV status to our baseline model. First of all, it doesn't do anything to our model. Adding these sort of extra observations and then controlling for the HIV status, it's only the marital status is statistically significant. HIV positive status is not statistically significant. And then when we look across all these different forms of obstetric violence, we can see that sometimes the HIV status is significant, but it indicates that these HIV positive women are at a lower risk of experiencing physical abuse, non-consented care, and non-dignified care. Interestingly, they do not report, so we don't find any evidence that they are discriminated against. They don't report more often than other women, ceteris paribus, that they are discriminated against. Okay, so let me summarize the results. In our study setting, we've got a high prevalence rate of obstetric violence. So 65% of all the women we interviewed in these sort of postnatal and immunization clinics, that they experienced some form of obstetric violence. So the most common forms of obstetric violence were non-confidential care, neglect, non-dignified care. So this was the shouting and the humiliation and the physical abuse. Stitching without anesthesia is the most common physical abuse. And like other comparable studies for other countries, we found very few significant correlates in the regression analysis. Interestingly, against this sort of commonly held view that this is more of a problem in rural facilities, we found no evidence for that. Married women experience less obstetric violence. We find some evidence for that. We find some weaker evidence for less educated women experiencing more obstetric violence. So we find that HIV positive women do not experience more obstetric violence. Remember in particular that physical abuse was less common. This might be because medical staff are worried about infection risk to themselves if they physically assault an HIV pregnant woman. Deliveries by doctors are associated with lower levels of obstetric violence. This might, though, be due to them attending to cesarean sections, which have lower rates, of where we see lower rates of obstetric violence. Okay, so we can conclude that all women who deliver in any of the 8 public health facilities that we studied in Ghana are at a substantial risk of experiencing obstetric violence. So it's a problem for all women. And this really helps to explain the reluctance of women to deliver in facilities. And it clearly undermines the Ghanaian government's effort to decrease maternal mortality rates and the prevention of mother-to-child transmission effort. So what's next in our research? So first of all, we need to report back to these healthcare facilities and discuss our findings with them, and also obviously consult how they might want to assist us in further research. They were all very open to this research question, otherwise they wouldn't have consented for this research to take place. So we're very hopeful to sort of continue collaboration. So in general, we need to collaborate with healthcare professionals to develop interventions that reduce obstetric violence. So this is partly, we think, a problem of training. Not enough emphasis is sort of put on positive birthing experiences giving the best outcome for mother and child, but also partly a socialization issue of young midwives, freshly trained ones, being socialized in these public healthcare facilities into all of these this use of obstetric violence in the delivery room. So once we are a bit clear about which intervention we prefer, we'll pilot this intervention and analyze the intervention in a cluster randomized control trial. Let me end by thanking all the women who took part in this very difficult study, very sensitive question, sort of opening up this trauma, and also the enumerators. They were all young women themselves. Some of them had also had similar experiences of birthing in Ghana. So I thank them particularly for their effort in this difficult study. Because I should say, because of COVID, we couldn't travel, and so we were extremely reliant on our local partners who did an excellent job.